Dear colleagues, welcome to this happy hour of the symposium. I'd like to thank Maria who invited us to join the Ocular Oncologist with this cornea session. Distinguished colleague will present you interesting cornea topics. We will start from a well-known all over the world, Professor Tassos Kanellopoulos. His lecture is on neoplastic and infectious surprises in anterior segment diagnosis and treatment. Tassos, you're welcome.
Spiros, thanks so much for the introduction, and thanks for being a leader in eye surgery in Greece all these decades. It's really a pleasure and honor to be here. Star cast in oncology, and of course, I will myself thank Maria for organizing all this. It's really a pleasure to be here. Little shift in gears here, since I watched a lot of the oncology talks by my friend Carol earlier. My talk was essentially the one that she showed of removing CIN from the conjunctiva. So I will switch gears here and I will speak a little bit about therapeutic refractive surgery and the lessons that we've learned over the decades. These are my financial disclosures on the subjects that I'll be speaking of. And we know here in Europe, and for our US colleagues, I will apologize, that since 2003, we've had a tool that was designed to treat sick corneas, irregular corneas. So this was topographic guided ablations. It only became FDA approved 5 or 6 years ago. So for almost 20 years, we have been using this technology, and we're seeing here some of our work here from Greece to enlarge small optical ablations, as you can see on the top left, treating irregular corneas such as ectasia on the bottom left, treating, which is very interesting, a herpetic scar in the middle bottom before, after, and the difference. And you can see how specific the topography guided can be in treating irregular corneas. And when I trained in cornea in the U.S., both with Hank Perry and Eric Donato in New York and Klaus Doman in Boston, these corneas we had to transplant if they were contact lens intolerant. So we were able to use this technology therapeutically side by side with wavefront technology. The problem with wavefront is, as you can see here, it's a dynamic measurement. So when you want to treat irregularities that are in the cornea, it may make more sense to use the topography guided platform rather than wavefront guided platform, as the wavefront is dynamic. And this is wavefronts of different patients studied through time. And the question is, which one do I treat on a single treatment with my topography guided device? Of course, when we're talking about topography guided treatments, and I can speak all day on this, I'm going to stay within 10 minutes. The first thing that we have to make sure is that we clearly understand what the diagnostics give us today. So to do topography guided treatments, it requires a strong and severe learning curve that may not be on the daily basis of the agenda of a general ophthalmologist or a retina surgeon or a ocular oncologist. And there are several lessons to be learned from there. So I mentioned that we have been working with topography guided treatment since 2003 in Europe, but it was only when the FDA approval came in 2013, which was performed on virgin myopic eyes, that we learned a lesson that when using topography guided in virgin myopic eyes, the visual outcomes were superior to any other platform with excimer laser that has gone through the FDA. So this lesson is very important, and I'm going to try and explain why within this slide. We're seeing a patient with what we will all agree, regular with a rule astigmatism. We can see that topographically, the cylinder is right at 90 degrees. Interestingly enough, the refraction of this patient is at minus at 45 degrees. So 135 degrees plus axis. Why is that? That's because if we look at the bottom right, the patient has angle kappa. And this regular astigmatism for the patient acts as a prism. So when the patient refracts, they have to incorporate astigmatism arbitrarily through the coma that the displaced cornea astigmatism is creating to have a feasible and a helpful refraction for that. So this is the lesson that we learned in topography guided. If you treat this eye with a standard wavefront optimized ablation, you should treat the refraction that the patient chose. The problem is if you decide to treat this eye topography guided, topography is going to neutralize the topographic cylinder that we're seeing, and the refractive cylinder of the patient will change. So this is the lesson learned on how to blend the clinical refraction of the patient and the topographic refraction of the topography device. And we named this TMR, topography modified refraction, to be used in topography guided ablations. We published this in 2015. Of course, it's very laborious because you have to go back and forth, see the difference between the axis and the astigmatism of the clinical refraction and the topographic refraction. Of course, in most patients, those two are the same. Only 20-30% of patients have a disparity between their topographic cylinder and their refractive cylinder in amount and axis. And this is when we compared going 50% towards the topographic cylinder in axis and 50% in power versus 100%. And we showed that if you only do a 50% blend of the topographic data, you gain 2 or more lines in the visual correction of these patients. And we've seen this when we compared LASIK and SMILE. SMILE is a brilliant procedure. It became FDA approved to treat cylinder as well this last year. When we compared topography guided LASIK with TMR and SMILE, we found that LASIK was superior just because it does treat the topographic cylinder and all the aberrations that generate from that. This is comparing LASIK and SMILE 2 and 3 years out, and these are the epithelial maps, and we've shown that these two procedures are more similar than dissimilar, and we're waiting when SMILE can be customized and do this. And I'm going to speak a little bit about combining guided treatments and cross-linking, and our team here in Athens has worked a lot in introducing new techniques of cornea cross-linking, and this is our first landmark paper in the Journal of Cornea. I was asked to, and I'm finishing this month, an editorial combining excimer ablations and cross-linking by the Journal of Cornea. We've had over 25 publications in that journal studying a very large amount of patients. What we're seeing here is on the top left, a keratoconic eye before and after cross-linking. We can see that cross-linking offers a little bit of flattening, which we're seeing in the third picture at the top, 1 or 2 diopters, but the patient remains intolerant of contact lenses and very difficult to visually rehabilitate. So we took the deep breath and did the heretic approach, do a excimer ablation on a keratoconic eye that's quite thin and treat the cone, which is what we were taught that we should not treat. We should not thin an area of the cornea that's already thin. Well, the reward was that bottom left, that the cornea normalized significantly. The patient could function with a soft contact lens. We can see right next, the next image on the bottom left shows the difference that achieved with topographic guided treatment, while the other eye worsened. And this is where all the combining CXL and partial in refraction topographic guided treatment generated the Athens protocol, which is now one of the key procedures globally. Our treatment today is treat first the topography guided segment, then do a PTK that accounts for the epithelial removal, mitomycin C for 30 seconds, and then cross-linking 6 milliwatts for 15 minutes. And these are the representative results that we get before, middle, after. And we can see that when you combine the two, you get flattening of about 11 diopters, which is impossible to get if you do a 1 or 2 diopter excimer ablation separate than the cross-linking that would also give you 1 or 2 diopters of flattening. So in order to get 10 diopters of flattening, you have to combine the two. And this is a curl of the Athens protocol. Here we're seeing the most changed parameter, the IHD, index of high concentration, went from 146 to 29, almost normal in this patient. And again, this is something that we would apply mainly in patients who are contact lens intolerant. In Greece, this is the majority of patients. In Northern Europe, it may be the minority, and this may not be necessary. And we've published over 1,000 carefully studied cases with the Athens protocol. different techniques. Of course, this comes with some complications, delayed field healing, anterior corneal scarring. You may, over the years, and we presented our 10-year data a few years ago, get over flattening of these corneas, and they turn hyperopic, but then again, you can do hyperopic with surface ablation. We've published the psychometric quality of life changes, which are drastic for these young adults. We've combined it with topographic guided CXL. We were the first team in 2013 to use topographic guided patterns of UV light and fluence. And I will close with a small quiz. This is a New York patient. I saw him in my Manhattan office. A lawsuit for post-LASIK aphasia. Well, not really, because if we look at the pentacams, the steeper part of the cornea is not the thinnest part of the cornea, and the backside of the cornea is normal. So this is just a decentered mixed astigmatic ablation. Does not need CXL. And this is the result of treating keratoconic eyes with a very frugal ablation, 1 or 2 doctors combined with CXL, and topography guided, becoming a refractive procedure that can have a very significant therapeutic footprint in these patients. Our last publication in the Journal of Cornea last year is using ray tracing, which combines topography data and wavefront data. Not enough time to talk about this right now, but this may hold a promise for the future. I think that I used a lot of my time. I want to thank Maria Pascanaki and, of course, Professor Ilvaras for me allowing me to present to you, and I hope you enjoy the rest of the meeting. This is John Canalpa. Thanks so much.
Thank you very much, Professor, for your presentation. I think that we can discuss later on your topic.
Okay.